Welcome to the Catastrophic Comeback Podcast with American injury lawyer Clark Speaks, helping you find hope, purpose, and joy after a catastrophic injury.
What percentage of your patients do you feel like you see telemedicine versus in person?
Wow. I don't know an exact, but I would definitely say it's growing. It would not surprise me if it's at least a good 40%. It might even be 50%.
Are there circumstances in which you have to see them in person?
Oh, for sure. It's always, ideally, you definitely want to have an in-person physical exam if possible. But there are certain diagnoses that may not require it nearly as much, or certain circumstances where it's just not going to be possible. They live, 300 miles away, or do not have access to a vehicle. But ideally, for a lot of the orthopedic conditions that I evaluate, I'm able to do an exam that's of sufficient quality to be able to care for them in an adequate manner that is not going to compromise their health. And so we're able to do quite a bit via telemedicine. You can talk to the patient. You can do a more focused physical exam, but an adequate physical exam for the patient in most circumstances. You can review their labs. You can review their imaging studies, because now a lot of that stuff is online. So you can actually share your screen with the patient and show them in real time. Here, this is the MRI, this is the CT scan. You see your shoulder, it's right here. Here's the problem, and point it out to them. Show them their lab values, all that kind of stuff. So with the benefit of technology, you can do so much in a much more time-efficient manner.
So I guess you're able to take a history. You're able to review notes. You're able to talk to them about what happened to them. You're able to see film. You're able to see the imaging, the X-rays. You're able to see MRIs, MRI reports. So you have all of that information there, and you can ask them the questions. I guess the only thing that you couldn't do is just like put your hands on them or ask them to do this or maneuver them in a certain way.
There's certain physical exam components that you would not be able to do, but there are others that indeed you can do. You can still do assessment for motion, for range of motion, for strength. You're going to get the basics. If they're standing up, you're going to know that certain motor muscle groups are functioning to a minimum amount, and so there's still quite a bit that can be done via the telemedicine platform.
And then if you need to do a surgical procedure or therapy, you can just prescribe it from there, and they come back and
Correct.
receive it.
Ultimately, if we're doing surgery, we certainly want to be able to evaluate them at one point. Oftentimes, though, they can be evaluated by another similar specialist. So within orthopedics, for instance, in my practice, we also have doctors that are non-surgical orthopedists, which is called physical medicine and rehab. But it's basically an orthopedist who doesn't operate. They can do physical exam on the patient. They might see him in a different clinic than me, but I trust their physical exam. Then ultimately, I may see them via telemedicine and say, yeah, I do think you need a neck surgery or a back surgery. And then possibly the morning of, when I actually see them in the operating room or just before the operating room at the hospital or in the surgery center, I'll do a physical exam just to confirm that that's what the non-surgical orthopedist saw, make sure everything lines up, and then we proceed to surgery.
So would there be physicians in each one of your different offices, doctors in each one of your orthopedic doctors in each one of your different offices?
We do have multiple orthopedic doctors, multiple physical medicine and rehab doctors. We have nurse practitioners. We have PAs. Physician assistants are PAs, and nurse practitioners also function helping the doctor. They can be to a certain degree independent and can take care of patients independently, but they still work with the doctor that's supervising them to deliver health care.
Okay, so you're in charge of that whole group, and then in
Yes.
addition, are you the only orthopedic surgeon in your practice?
No, we have several other orthopedic surgeons. We have two general orthopedists that do extremities. So extremities, we mean arms and legs. So that means shoulders, knees, ankles, wrists, elbows. We also have two spine surgeons. I'm one of them in the group. We have 3 physical medicine and rehab doctors in the group. We have a couple nurse practitioners, and we have multiple physician assistants.
Yeah. So technology is something that's gone a long ways towards helping you be able to help more people, treat more people, improve the lives of the patients that you are able, more people that you're able to treat.
Oh yeah.
One of the things that we're looking at in this podcast is, people that have catastrophic injuries. Not all of our cases involve catastrophic injuries. So most of our cases involve people that get that have they're driving down Independence Boulevard and somebody rear ends them. They're driving down Market Street. Somebody pulls out in front of them. And they get treatment. Maybe they have a consultation. There's a course of physical therapy. There's a reevaluation. But some of the cases that we're involved in have more serious, lifelong challenges, either paralysis or, some cases death, and then sometimes it's like just a serious back injury that might involve surgery, might involve fusions, might involve future medical treatment. Do you deal with some of those issues?
We do, just because that's the nature of orthopedics, is dealing with injuries. So it's not just conditions that you might be born with, but it's also acquired things that happen during your lifetime, which trauma can be, falling off a roof. Or I was speaking with somebody the other day about a patient that I had who was on a fan boat in the Everglades, and they hit a stump and he fell off and got his leg cut off, unfortunately.
Oh, wow.
And it was a young kid. So that would be a catastrophic injury. It's gonna be life-changing for that boy, to have to deal with the loss of his leg, not just the psychological aspect of it, but the physical aspect. It changes your body, obviously, when you've had an amputation. And this young man, he was like a 18, 19-year-old kid, and we had to deal with the amputation. We had to prepare the leg to be able to close the wound, and obviously the water in the Everglades is not the cleanest, and there was a large infection there. We had to deal with that. We finally got that cleaned out, get the wound closed, and then you have to prepare the leg to be able to fit into a prosthesis. There's a lot that goes into that, and then ultimately just not only the psychological aspect of that, but then just the physical, because you're now missing an extremity. You're going to have to redistribute all of those energies of movement, of ambulation, to your other body parts. And so that's going to affect those other body parts. So you tend to see that a young person who's had an amputation, they're going to be using crutches a lot more. So they're going to be putting a lot more pressure on their upper extremities, their arms, for the rest of their life. What impact is that going to have on them? Well, you're going to see a much higher chance of having elbow issues, wrist issues, rotator cuff tears in those people. That was back in my training. So that would be 22, 23 years ago. So he's not a 19-year-old now. Now he's middle-aged, maybe 40s. 40-somethings don't tend to just get rotator cuff tears, injuries in their shoulders, unless, they're doing a sporting activity or some sort of work-related thing. But it's not a common thing. But in somebody who's had an amputation, yeah, it's actually quite common by that age, because they've put so much pressure for the last 20 years on their arms, having to walk with crutches. So that's something that you have to keep in mind, not only for the patient, but obviously for y'all's specialty as well, is that's going to be something in the future that they might have to deal with at a much higher chance than the general population would.
So it's funny you mention that. So we've talked about that several times this week. One of the things, so where we get involved is after something traumatic happens to someone, if there is liability, if someone else caused it or contributed to it or whatever, then we can sometimes get in and try to get people the financial compensation that will allow them to pay for medical treatment, to pay for lost wages, to compensate them for pain and suffering. And so it becomes a situation a lot of times in some of these catastrophic cases, how well we can document the impact that this accident or injury has had on a person's life and a person's family. And it's pretty easy to pull medical records I mean, you got the hard job in this whole thing. You got to put people back together. From our point of view, at that point, we're pulling medical records, we're pulling the investigative materials and all that. Where it gets a little bit more challenging from our perspective is where we have to try to figure out how to quantify loss, and the way to do that is to figure out, okay, what types of future problems might this person have, and so that's why it is critical for us to be able to talk to people. And not every physician, in my experience, not every physician understands how important it is to quantify that future element of recovery of the not just physically, what are the challenges that a person who's has a permanent injury might face, and your example of the amputation is a perfect example, right? But also financially, emotionally, you know what I mean? What's the emotional impact of that? But financially, if that person is on crutches, or if that person is now having to shift weight to the other leg, and that other knee gives out, that other hip has problems, requires therapy, requires replacement. And then also, I can't help thinking, my mother is 86 years old, and we're real close, and she's lived with our family for a long time, and I keep thinking, what about when a person's that age? What are these permanent injuries to this knee or to this hip due to the rest of the body over time, and what's the impact, and what's the financial and physical cost of that going forward?
We have a finite number or limited number of joints and muscles in our body, and they handle all the stresses of our life and day-to-day activities. If you miss some of those, or you lose some of those as a result of injury or infection or whatever reason, necessarily those stresses have to be now distributed over what's remaining. And those other body parts have to pick up the slack and work harder, and so they can wear out sooner. That's like what we do. For me as a spine specialist, we will often treat a damaged or worn out joint in the neck or the low back by gluing that joint together, and that's called a fusion. When you glue a joint together, that gets rid of those two bones that are rubbing against each other and the pain coming from that. But the problem is that once you've glued that joint together, the other neighboring joints have to pick up the slack and work harder. So 80 years ago, we didn't have knee replacements. So we just glued people's legs straight, and they would have to walk with a straight leg. And what we saw from that was, man, those people that are walking around with a straight leg like that, they're wearing out their ankle a little bit faster, but they're definitely wearing their hip out really fast. And so when that technology came along to be able to replace a joint rather than glue that joint together, we've started doing that as within the orthopedic community and seeing a big change. And so now we've had artificial knees and artificial hips for decades now. In spine, that's only finally showed up in the last 20 years or so. We now have artificial discs for the neck and for the low back. And what we've seen is that does have an impact, because when we glue a joint together in the neck or we glue a joint together in the low back, the other remaining ones do work harder. And so there is an increased chance of those neighboring joints to wear out. And now with artificial discs, we're not seeing that increase. So that has a big impact. And it's important for the physician, for the orthopedist, to know that, so that they can speak to y'all's profession, the legal community, to be able to inform y'all, okay, this is what is going to be Mrs. Jones is going to be facing for the rest of her life. Trauma, orthopedic traumatologists, so the orthopedic specialists that just deal with trauma, people that go to the trauma center with a broken pelvis or a broken thigh bone called the femur or whatever, they're often treated at a trauma center by traumatologists. Those doctors, those specialists are probably can be very helpful for giving what would be expected future issues for a patient like that after a major traumatic event. There's in fact a whole industry that deals just with that. They're called life care planners, as you well know, and those are folks that can help kind of map out, okay, this is what Mrs. Jones is going to need in the future as a result of losing the all of the toes on her right foot, and she's not going to be able to walk as well. She'll need therapy. She'll need a special shoe, prosthetics and orthotics.
It might wear out every 6 months, and she might need to replace it.
Yeah, that's what those specialists do. They know all that information, or they've studied that, and then they'll work in concert with the doctor, because the doctors may not always know all that stuff. They might know, oh, they're going to need, when you've got an amputation, you're going to now need a special bed to sleep in, or you're going to need a harness to get you in and out of the shower to be able to shower, and that harness will wear out probably every couple of years, and Mrs. Jones is only 32. She's going to live another 48 years, so you're going to need probably 18 more harnesses or something like that. That's where life care planners can help inform the doctor, and then together the doctor along with the life care planner can come up with, okay, this is likely what Mrs. Jones is going to be facing and going to be needing for the rest of her life.
So we had one of these life care planners, Sean Seaver, on a couple of months ago. So she's in a previous episode. We'll try to provide a link to in this episode to that one, so people can see a little bit more about what you're talking about. Thank you for joining us, and we'll see you next time.